Thank you, Dr. Chauhan, for giving me this honor of moderating this 835th weekly CME of the Physicians Forum of India. I welcome all of you here, and it also happens to be a World No Tobacco Day. So it's really thrilling that we are having a discussion on obstructive airway diseases on World No Tobacco Day. Today we have the renowned pulmonologist Dr. Prashant Saxena with us, with whom we had innumerable CMEs during the COVID times and later on also. And we are all really grateful to him for sharing this knowledge he gave us during COVID times that helped us in treating our patients when the whole world was actually doing quackery around COVID-19. He's the director and head of pulmonology, sleep medicine and critical care at Max Smart Hospital. But he will be very soon joining his new abode at Fortis Hospital, Vasant Kunj. And we wish him all the success there also and in the future career as well. He has undergone his fellowship training at Westmead and Liverpool hospitals at Sydney in Australia, and he has also had interventional pulmonology training at France, Italy and Greece. He is also famous for the rapid response teams and antibiotic stewardship programs that he had. He holds a clinical expertise in critical care, and other areas of expertise include COVID-19, COPD, flu, asthma, pneumonia, lung cancer, interstitial lung diseases, tuberculosis and sarcoidosis. He is also the clinical supervisor of MRCP UK and a teacher for the IDCCM, a course which is done after post-graduation. So, we welcome Dr. Prashant Saxena. Please welcome him with a big round of applause.
So, thank you, Dr. Paul sir, for a kind introduction and definitely pleasing words. And thank you, Dr. Chauhan and the Physician Forum of India for inviting me yet again. And I believe it's the 7th or 8th CME post-COVID, but probably we have done around 12 CMEs with this forum. And it's always been a pleasure. I always see a learned crowd listening so patiently to the advancements, especially in pulmonology. And my talk has always been intended to deliver the basics and the problems which we encounter, and any physician or any surgeon can encounter in his or her practice. So the intent has been to deliver the very brief overview of the present day issues. And one such issue is OAD, or Obstructive Airway Disease. And Obstructive Airway Disease comprises of not only asthma, COPD, emphysema, bronchitis. Today we are seeing it as an epidemic, and we have been talking about tuberculosis, HIV. But COPD or OAD is coming up as a real big challenge, because the problem is it is not diagnosed early. It is often missed, because in the young age you are got a good muscle strength and you don't perceive those symptoms, or you don't attend to the doctor. And by the time you develop the symptoms of COPD or asthma, it is already too late. And it's become a challenge to manage these. So I would be discussing both today, and first we'll discuss about asthma, and I'll give you a present guidelines. What are the changes and what is new in these diseases. So first of all, the definition of asthma which has recently been proposed by China is that it's a heterogeneous disease, and it is usually characterized by chronic airway inflammation. So why they want to tell you is that it's a chronic airway inflammation. It is not an acute inflammation. So it's a chronic disease, and you will have symptoms which are variable, and they have added this line that airflow limitation may later become persistent. So this is very important for us to note, that if you are not treating these patients properly, you will have a persistent problem which will not improve despite your medicines. So that is the message from this change in the asthma definition. They have also identified phenotypes of asthma. Whenever you talk about asthma, people think about allergies. कि कहीं ना कहीं एलर्जी होगी इसलिए asthma होगा. But you look at the phenotype. Apart from the allergic asthma, there are non-allergic asthmas. There is adult onset or late asthma, asthma with fixed airflow limitation, and asthma with obesity. These are all which have been identified, and they all need to be addressed because it is the importance of history taking which is there whenever you are evaluating a patient of obstructive airway disease. This is just to summarize what we actually do. The most important takeaway from this flowchart is that it is a very careful evaluation by history taking. If you have taken a very careful history, you can diagnose asthma, you don't need to do any test. Still, the first investigation of choice will be after history taking to do a pulmonary function evaluation, which most often we don't do. And along with that, you can support your diagnosis with a few blood tests, which may include eosinophil counts and Ig levels, which may help you in further management of the patients. An X-ray or CT scan is not essential for the diagnosis of asthma. Most of the time, we take the history of variable symptoms, wheezing, and then we diagnose asthma. But some of the times we miss asking them the potential triggers. So I wanted to highlight these triggers which are very important. So even if you have a no smoking indoors, so we ask the patient that is there somebody who smokes? They say no. Then that story is over. But then one of my patients I asked, is there a smoker in your house? They say no, there is no smoker. हमारे पूरे खानदान में किसी ने smoke नहीं किया. Very good. But then I asked, what do you do in the morning? They said, sir, रोज सुबह हवन करते हैं हम लोग. बहुत बढ़िया. भगवान की पूजा करते हैं. ठीक है, very good. So immediately I got the. But the problem is you have to tackle them very carefully because you cannot say कि हवन बंद कर दो. It has to be a very good conversation because otherwise you may become a culprit in their eyes. So these are the triggers: indoor airway pollution, pollens, wet walls. Now this is something which I wanted to highlight. I have recently seen a lot of patients who have these areas in the bathroom or somewhere in the corner of the drawers where there is a sealant, and so I always ask कि घर में कोई sealant है कि नहीं है. Now why the sealant is important? Because this is a potential for development of fungal infection. There could be a fungus which is growing here. Not only fungus, these fungus have the tendency to disseminate spores in the air. So it is not that you have to touch the wall. It is since all of us have got air conditioners, so these spores circulate in the air and they can infect you. So it is important to look at the figures. Then we have to understand the terminology. I would just tell you that there are medicines which are known as relievers. Reliever is only the medicine which is to be used on a SOS basis, which is your aspirin. But it has changed now. We don't use aspirin now. We tell you controller medications are those medicines which will control your symptoms and which will prevent the exacerbation or the risk of exacerbation. And maintenance treatment is a treatment which is given for the patient and which has to be taken every day. And this is the most important aspect. We have to tell the patient. We ask them to review after 2 weeks or maybe 1 week. And most of the patients come to me, they tell me कि डॉक्टर साहब 2 हफ्ते में ठीक हो गए थे, आपने बहुत बढ़िया दवाई दी, and now I have stopped the inhaler. Now tell me what to do. So this is the most frequent presentation of patients who come for follow-up. They stop the medicines because they are okay, but you have to tell them it's a chronic disease. It has to be tackled with not only the symptoms, you have to document the improvement also. So coming to the favorite aspirin or salbutamol inhaler, the blue inhaler. Everybody, probably even today, I see patients carrying this inhaler in their pockets and they tell them that our asthma is controlled. Then when further screen them, I ask them what is the medicine you are taking which is controlling your asthma. they tell me they are taking this inhaler, SOS salbutamol, which is there. And जब भी problem होती है डॉक्टर साहब, we take this, and it is a wonderful thing. They have told now there is ample of evidence that this is the medicine which should not be used, and they have even told that if you are using more than 12 canisters per year, I have seen patients who are using 12 canisters in a month, associated with a higher risk of death. Because beta-2 agonists, we know, heart rate, tachycardia, cardiovascular side effects, are a lot of side effects are there. So they have removed this from everywhere, as you can see in these guidelines, which have come, the latest guidelines of asthma control, and it is very simple guideline. If you for the reliever, instead of aspirin, now they have a combination of inhaled corticosteroid and formoterol, which is the usual inhaler, which means even for the SOS use, you can use the same inhaler. For example, Seroflow or your Foracort. We use Foracort, but you can use the same inhaler. And this is a step-ladder pattern. You have to increase the dose of steroids, and then finally, if the asthma is not controlled, you can add a LAMA or think about anti-IgE therapy or anti-eosinophil therapy. So this is how it is. Usually we have got patients who come into the step 1 to 4. If you follow these patients properly, you don't have to take them to step 5 where you have to give a lot of emphasis on these other treatments. So my worry is always to take the patients and keep the patients in these step 1 to 3. I don't want the patients to cross these, steps, because it becomes difficult then. So the other changes are there. They have also told that people who are dark skinned, the SpO2 readings may be false. So please remember, you may have a higher level of SpO2 in people who are dark skinned, including Indians. It is not only about Nigerians. We have dark skinned Indians also. And there is an interaction of inhaled corticosteroid, salmeterol, and inhaled corticosteroid bilanterol combination. These are new combinations with the COVID drug, which is the ritonavir and the nematrelvir. So it is very important to note that if you have asthma, and you should be aware of these things. And please don't do CT in every patient. Whenever we see a difficult patient of chest, wheezing patient, we always rush to get the CT scan. They have not recommended it. So avoid that. So this is the summary of whatever I have told you. That instead of the salbutamol, please try to use the combination inhaler, and they are effective, safe, and please don't use the term mild asthma. Patient comes to you, you diagnose asthma, patient will always ask you, Dr. Sahab, mild or severe? And because you want to satisfy the patient, you will tell the patient, abhi to mild hai, control ho jayega, and then you will see. Please don't tell the patient that it is mild or severe. Asthma is asthma. COPD is COPD. You have got a disease, and if you don't follow the instructions, it will become very bad. That is what I tell my patients. I don't tell them whether you have mild, moderate or severe. Because if you tell them mild, he will immediately click that thing in his or her mind. They will take the error ki mild is happy, theek ho gaya, ek mahine mein to band kar diya. So this should not be the message. And I have seen people coming with LAMA only monotherapy, which is your tiotropium. So don't use this only as a single inhaler, because it is not recommended. Then coming to a very small case, and which is a 28-year-old patient, childhood asthma, but by the age of 13 years, this patient became alright. And now he comes to you, the patient is not 28 years old. So till 13 years there was asthma, now the asthma disappeared. 28 years, the patient comes back to you, there is chest tightness, symptoms are relieved after rest. And there is no nighttime symptoms, and you perform spirometry and all. Then we found out that the roommate was a smoker. The patient was not smoking. We asked the patient, do you smoke? The patient said no. Please always ask whether your friends smoke. I will tell you an interesting story. One of my male patients, 20, maybe around 32, he came to me that I have a asthma which is bad only when I am in the room. I asked every history. I asked him whether there is ceiling, whether there is this, that, animals, pets, everything, agarbatti, dhupbatti. I couldn't find anything. And I am outside, okay. When I go, okay, who do you live with? He said, I have a partner. Wow. Okay. What is your partner? Obviously, there is a female partner. And he told me she is a chain smoker. Okay. So, you have to actually dig into the things when you have to take history of such patients. Because small clues can help you many. And I asked just to avoid, I don't know how he must have avoided that. So, that is another challenge, to help them quit smoking. So he was recommended an inhaler and then asked to avoid the smoke. So coming to COPD. COPD, chronic obstructive lung disease, cough, dyspnea, sputum, coming every year. Old definitions are there consecutively for 3 months and 2 years, but now they have changed the definition, and there is a progressive persistent airflow obstruction. So COPD patient, if you don't treat, it is a progressive persistent airflow limitation, which means if you are not treating COPD patient, he is going to die. This is very clear. They have included two terms, pre-COPD and PRISM. Pre-COPD is a patient who has got a PFT which is okay, but he has got dyspnea or symptoms consistent with COPD. Then coming to PRISM. PRISM is a patient who has got a PFT where the FEV1 FVC ratio is normal. We diagnose COPD on the basis of FEV1 FVC ratio if it is less than 0.7. So the ratio is normal, but the FEV1, the forced expiratory volume in 1 second is low. So this is PRISM ratio impaired spirometry. Now why we want to know these patients? Because both these category of patients, if you are not treating them, they will develop COPD. So it is important to screen these two category of patients. Then there are other subsets of COPD now. Whenever we talk about COPD, smoking comes into our mind. But this is not the scenario. You can have a genetic COPD, you can have COPD due to your problems in the childhood, environmental COPD, cigarette smoking we know, biomass, COPD due to infections, COPD due to asthma, COPD due to tuberculosis, COPD due to persistent COVID, we know. All these things are possible. Now, screening is important. I just wanted to show this highlight because whenever you encounter these patients, please do a screening test, please do the history taking, at least do a pulmonary function evaluation. It is not for every patient, but patients who are symptomatic. There is another problem which we frequently encountered, which is this chronic bronchitis, and there is a patient who comes to you with cough and sputum on a regular basis. Every 2-3 months the patient will come, I am having this cough and sputum, and you examine the patient is not having typical features of chronic obstructive pulmonary disease, but he does have cough and sputum at regular intervals. Then we have to evaluate these patients. The prevalence is pretty high, especially in people who are living in polluted cities, and close to 20% are never smokers. So this is important, and GERD is very much common in these patients. So why I wanted to highlight that, please manage the comorbidities, not only GERD but your sinusitis, rhinitis, obesity, sleep apnea, so many things, heart failures, cardiac comorbidities, so many things which contribute to this chronic bronchitis. This landscape, this is what is a basic assessment tool. I would not go into the details, but I would like you to highlight here. Now what they have done, previously it used to be ABCD. Now there is A, B and E only. It is very simple. This is for COPD. You do a PFT, and if your PFT, FEV1, FVC ratio is less than 0.7, means you have a COPD. Okay? After that, you look at the FEV1. And then, according to the FEV1, if it is more than 80, it is 1. It is 50 to 80, it is 2. Like that, you categorize 1, 2, 3, 4. Right? So this you can do. Then you take the history taking. If the patient has got a history of hospitalization of more than equal to 2 exacerbation, it will be E. Otherwise, the patient is A or B. This we can take out from the history. And if the dyspnea score is higher, the patient is B, otherwise the patient is A. Why it is important? Because the treatment changes, the therapy changes. And what is important to note in that, I have probably, or every one of you must have noticed, that CAT is a clinical assessment tool. It is a questionnaire where there are 10 questions. And they give you numbers. For example, are you breathless while changing clothes? Are you breathless while walking? Are you comfortable sleeping? These simple questions. The patient will fill 1, 2, 3, 4, 0 to 5 score. And then you calculate the score and that is the CAT score. Less than 10 or more than 10. So the C comes into E. It is very simple. Usually this is what we get. This is what you get. The patient is B or E. A तो मुश्किल से मिलते हैं patients estimate में, who don't have any of these problems. So lava lama is a thing which they have proposed. So please, the important thing to note is that there is no inhaled corticosteroid. There is no zero flow or there is no furacort in COPD patient to start with. That is the message. Inhaled corticosteroid is not there. Inhaled corticosteroid, yes, for group E patients. The indication is patients who have got a eosinophilia. Peripheral eosinophilia more than 300 per microliter, or patients who have got very severe symptoms, or patients who are already on an inhaled corticosteroid inhaler combination and not getting control, then you want to add another therapy. These are the only 3 reasons why you should have an inhaled corticosteroid in a COPD. Otherwise, your patient will do well with this combination of LABA and LAMA. So, management. The plan is to make management easy. Previously we used to give, I am taking the names but I am not promoting any company. We used to give furacort and Tioga, zero flow and Tioga. Now things have changed. They have combined these into a single inhaler, which is known as a triple therapy. And all these molecules are long acting, single dose. So you have to, in some of the combinations you have to give twice daily dosing, or in some combinations there is only once daily dosing. So what used to happen previously, we used to give them 2 inhalers. कि ये सुबह शाम लेना है, ये सुबह लेना। वो क्या करता था कि सुबह वाला लिया और शाम को ये जो सुबह आपने दिया है डॉक्टर साहब वो ले रहा हूँ। वो एक गाया। This is the usual scenario. So they used to taper it according to them. But this has stopped. We are combining them. This is another case. I'll just skip this in respect of time. So this is a patient which is a retired teacher and young smoker. Now abstinence, hypertension, dyspnea is there, and the dyspnea is progressively increasing. She has mild cough and started on fluticasone budesonide by the doctor, but still she is not controlled. There is a SpO2 which is okay, bronchi is there. Cardiologist doesn't feel it is a cardiac case and now refer to us. So these are the cases which we usually see. That there is no cardiac problem, I am already taking this inhaler doctor, I am on furacort, what are you going to do? So it is simple. We did the spirometry, we found that the patient is having an uncontrolled, there is so much reversibility. The patient is having an uncontrolled asthma at this stage, early COPD, sorry, and there is a good bronchodilator reversibility. So you can have a patient which is having reversibility, and this usually comes when you have inadequate control. So you can, so there is an exacerbation. So these patients who are on an inhaler, for example, for a long time, they can develop exacerbations. So during the exacerbations, you have to note that you have to identify the exacerbation, and then you have to diagnose it and then treat it. So usually what we do, There is a triple therapy, triple combination. There are a lot of trials which are there, which have come up in the last 5 years. I will not go into the details, the impact trials, ethos trials, a lot of trials. And they have recommended that if you are using these triple combinations, the all-cause mortality is reduced as compared to a dual combination. So this is what you have to do when you have an uncontrolled patient on dual therapy. And apart from this, you always look for smoking cessation, pulmonary rehab, look at the comorbidities, all these things you have to tackle. Not going into the details. This is something which is new, and I just wanted to highlight that we have got patients who have sputum productions, exacerbation, dyspnea. Because COPD patient, there will always be some problem. These are the patients who will never be satisfied. There will be dyspnea, there will be cough, they will say, Doctor, I am better 20%, I am 50% better, but 50% I am still there. And you have to just keep on working and telling them that yes, there is a problem, but we can manage it. But never say that it will be 100% correct. So there are new techniques, nitrogen cryospray, neoplasty, targeted lung denervation, they are all bronchoscopic interventions. I will just want to mention that this nitrogen cryospray is a technique where you just spray bronchoscopically nitrogen, which is minus 196 degrees centigrade into the segmental bronchi, and the plan is to destroy the goblet cells, which produces the mucus. Similarly, there is rheoplasty. This is again an electric current type of a device which is inserted in the carina, and then you can destroy the mucus producing cells. And these are all techniques which have come up. Just to mention, we don't have these techniques, but probably in a few years these will be coming up, because now we have got cheap devices. Because the problem with the previous therapies was that they were very expensive, but now we have got armamentarium which is available. So this is what the summary is, and I have already discussed everything. And as I told you in asthma, don't always do the CT. In COPD, I will tell you that at least do a CT scan. Because you may have a structural lung problem, you can have cavities, you can have bronchiectasis, you can have mucus plugging in the airways. So uncontrolled patients of COPD, I definitely could include a CT scan. And apart from that, vaccination, we all know it is very important, as with any other adult population in this polluted city. The COPD has got the same recommendations. So we know the goal of treatment is to control the current symptoms. So in COPD, patient comes, you tell the patient, okay, you have got dyspnea, you have got wheezing, let us control this first. We will control this. You cannot be cured, but you have to tell this very softly, because otherwise the patient will go to another doctor. So you have to control the symptoms and then prevent the future risk. Why this future risk is important? Because if you don't control the exacerbations, the patient will come to you, patient will take medicine, patient will stop medicine or reduce medicine, exacerbation will come, and the patient will again fall sick. It's a spiral which is going into the downward direction, ultimately leading to death. So we have seen there is a simplicity of treatment. We have got beautiful devices, beautiful combinations available, but you have to use them wisely. And most of the patients, you can see 70 to 80% of the patients are controlled with ICS LAVA combinations, medium to high dose. You don't even have to use a triple therapy if you are using the correct methodology. So this is what we have discussed. There are 5 different combinations, we all know. And physician preferences are there. I will not go into details, but I believe formatol budesonide combination is better. So this is what we can discuss later. Formatol budesonide again. So this has been shown in various studies that it is better than salmeterol fluticasone in terms of exacerbations, reduced cardiovascular risk, reduced mortality. So formatol budesonide is what the world is recommending nowadays. And inhaler very important. The problem which we have seen with the inhaler is improper use, incorrect use. People don't know. Simply, even I would not like to highlight this, but most of the doctors also don't know how to use inhalers, metered dose inhalers and rota inhalers. There are different techniques for both of them, and unfortunately the inhaler usage is very poor, because the problem is that the actuation, the timing of breath with the inhaler actuation is variable. The patient is not able to sometimes breathe properly or take the deep breaths. So we have got devices which are there and which are known as synchro breaths, which is synchronized with your breath, which means you have to put the inhaler in your mouth, and the moment you take a breath, the drug will be delivered. So you don't have to press anything, and the actuation is with your breath. So you can easily take the inhaler, and don't forget to ask the patient to do a deep gargle and spit out after taking the inhaler. So this is what it is. This is known as synchro breaths. They have got a dosage counter and very common nowadays. And most of us are using these. They are not expensive also. There is hardly a difference of 100 or 150 rupees in the normal inhaler and this inhaler. And lung deposition is also consistent and better as compared to the MDX. So this is what the world is using. It has been proven, and we are trying to optimize the therapy with these synchronized devices. And this can be used by elderly people also and young people also easily, because you don't have to take a very deep breath and you don't have to synchronize it. So they can take it easily. So this is the summary, and I would just like to say that smart approach is not a max smart, but it is single maintenance and reliever therapy, which means a single inhaler will be your maintenance therapy, a single inhaler will be your reliever. And anti-inflammatory drugs, please use them, simple devices, and always ask the patients what is better for you, which one is better. So they will tell you, and go by that, and always ask the patient if they can take a deep breath, because you know what happens, I always ask when the patient comes to my OPD, take a deep breath and show me whether you can take a deep breath or not, whether you can take an inhaler at all or not, and that is very important. If they are not able to take a deep breath, fast breath, then there is no point in prescribing inhalers, then use them right. Thank you.
So that was a very wonderful session on the various obstructive airway diseases. Sir, please come. Asthma, COPD, chronic bronchitis, and various practical aspects were so beautifully discussed.
As Dr. Vaisipal sir described, it was a wonderful exhibition of his skills as an orator and the substance that he carries in obstructive airway disease. We have a lot of people in the audience. We have Dr. Mangla sir, who is, as I said, champion of pulmonology. Dr. Alan Parashar is raising his hand. He deals with a lot of allergy, and therefore what I will do is I will go to these wonderful people one by one and ask for their opinion as to what they think about the talk and their own input and questions.
Well, I can't comment on such a worthy speaker like Prashant, but I would like to just make my comment as an ENT specialist. I see more than we get the CT scan done for the nose and sinuses. It is my chest physician colleagues who get more CT scans for the nose and sinuses, because these illnesses in the nose and sinuses cause too much of problem in the chest airway, because it is one single airway. It is only one airway. This being the comment. My other question was that since so much of your treatment policy depends on the pulmonary function test, recently we had our own health checkup, and we saw that earlier people who used to do pulmonary function test were much more able to tell us how to go about the thing, and this chap was not able to communicate properly, and therefore our graphs were coming haywire. So how much is this bias of the person getting the pulmonary function test, and how much does it influence the treatment policy overall?
I think a very valid point. It is about the technique of spirometry, and you know, if you are seeing the spirometries on a regular basis, I always look at the graph first and then I come to the report. So if you have read the graphs properly, then you can see the lines, how they are there. At least a 6-second expression should be there. And you can see whether there is a coughing or other variations in the lines. So by that you can easily make out whether the performance of spirometry is adequate or inadequate. And then obviously symptoms are not matching with the spirometry. That again is a clue. But I always look at the graph first and then the value. That way you can easily make out.
Dr. S.K. Poddar has a question.
My question is about Havan. You said Havan is a type of smoking, you can say practically. So, but Havan has many advantages also. So, can we do Havan with our doors and window open? Because there are some advantages of Havan also. So, what is your opinion? It's very, I think maybe may not be very scientific answer, but you should try to answer.
Yes, sir. It is a good practice to keep the doors open whenever you are having, ovens in your house. And nowadays we have, I will tell you one more thing. There is a smokeless oven samagri also. Yeah, so try using that.
Herbal.
On the laptop only.
I would request, I think the most relevant person in the audience is Dr. P.K. Magna sir. And he will not shy asking you questions and giving this CME some value addition.
A wonderful talk, Prashant. I think one thing is this 70% FEV, 1% FVC. This is post-bronchodilator. The value is post-bronchodilator. I think the COPD, asthma, they have a range. Like some patients will get better with little medicine, some patients you do anything, their symptoms just don't disappear. And at times you need to give them short courses of steroids, oral steroids. Otherwise, a lot of them come back that they haven't had a relief. You can give a short courses and they do well. And that is your decision whether this patient is, how symptomatic he is, how well he is going to be. And once you add that, then they are maintained on a combination of formoterol and fluticasone or budesonide. Regarding COPD, this treatment of lava-lama, it really does wonders. And these patients are worried when they start getting breathless or they have too much of sputum. I think getting breathless starts affecting their lifestyle. If they can't climb stairs, they can't walk with their friends. That is what bothers them and they come. And once you start this treatment, you are surprised that it makes a real difference to their life. And vaccinations are very important in these patients. I would like to add that we see a lot of critical care, the COPD, acute exacerbations, acute severe asthma, they form bunch of critical care. ICU admissions, 30-40% patients are like this. It is not straightforward COPD acute exacerbations because they are all smokers, and at times you find that there is an element of diastolic heart failure, and if you miss on to that, they don't get well with the standard line of treatment. And these patients can have acute MIs and LVF. Lot many times, all these patients are admitted under our care as a respirologist. The junior cardiologist who comes, he says, "Hamara to kuch nahi hai." The next day morning, you do their anti-proBNPs and all. Then you tell them that this is all cardiac failure. They'll write notes and go. So I think one has to keep all these things in mind. And this combination of lava-lama and at times this combination or triple combination, it has really made a difference. But earlier we were talking that they get extra pneumonias. This has been a thing. Extra pneumonia, but we wonder that asthmatics don't we give so much of steroid, they don't get so much of pneumonia. How come even if they get pneumonia, they are treatable? So this is that adding steroids whenever required. It's not logical to deny steroids if they are reducing their exacerbations. And lamas contribute more in reducing exacerbations over the beta-2 agonist. Thank you.
So your comment?
I think very well said, and one of the reasons I think in COPD, why we see more pneumonia, because COPD patients usually are on more oral steroids as compared to asthmatic. Because excessive patients, COPD, very difficult to control dyspnea and other symptoms. So the oral steroid usage is actually more. Plus, we have seen the studies have shown that the inhaled corticosteroids definitely on a long-term basis, because you are not able to taper therapy in a COPD patient if they are started on inhaled corticosteroids. And that's why the LAMA-LAMA combination we are promoting now, not for every COPD patient, inhaled corticosteroid is indicated. So that is there. And I think very well opinionated opinion about this LAMA-LAMA.
Actually, when these patients come in ICU, you feel that inka to lung hi nahi bacha. They are so breathless. But I've yet to see, in all my last 5 years, majority of patients you are able to discharge. And I agree whether you need to ventilate them. And when they come to your OPD, you realize that their lung function has really improved. They are walking and they really live for a long time. So it is not getting disheartened when they come with acute exacerbation, very breathless, PCO2 is high. You treat them with a standard line of treatment. Most of them do well.
I think that one of the very important points is ventilation. And as you emphasize, non-invasive ventilation is the first strategy. And if they go on a ventilator again, ventilating a COPD and asthmatic is very, very difficult job. It is just like ventilating a ARDS patient. So not everybody can do it, but definitely they improve, and there is a very few patients who will actually die of asthma or COPD exacerbation even on a ventilator. So the coming out of the ventilator is great. Huge chances.
So wonderful talk as always, whether it was offline, online, physical talks. Great, I would say, skills, Dr. Prashant. And we wish you absolutely all the good wishes on behalf of the forum for a brilliant career in Fortis Vasant Kunj. You did wonderfully well in next. I have a few questions, and I'm so proud that Dr. G.S. Grewal sir has joined us after, I would say, innumerable requests to come, and sir promised I will come to one of your. You are blessed, Dr. Grewal sir has come today. So my questions are very simple but relevant to many of us. COPD and asthma basically have inflammation at the basis, at the lower respiratory passage. But the similarity is not beyond that. We have inflammatory cells in COPD, but they are different. Basically neutrophils and lymphocytes and macrophages. But when it comes to asthma, it is not only these cells but the eosinophils which predominate at the cellular level. Are we targeting our therapy to the cellular inflammation, or we are targeting some other markers? Your comment on that?
I think very valid point, and the major advances, as I was showing in the step-ladder treatment of asthma. So if you have a high eosinophil count or a high Ig level, we have therapies to control that. But that comes, the important thing to understand is that comes only once you have exhausted your other armamentarium, which includes your combination of inhalers, which is your medium to high dose steroids and a LAMA combination, or a triple therapy, along with your leukotriene modifiers like montelukast. So if patient is not getting controlled, plus you have controlled the comorbidities, that is also very important. And then you feel, after looking at the blood test, that there is a eosinophilic inflammation or there is a high Ig inflammation. Some people have both also. Then you can use these biological therapies. And that is the difference from the COPD patients, where the inflammation is non-specific in nature, generally neutrophilic, and then there you use steroids. Steroids we use here also, but they don't affect the IgE and eosinophilic inflammation to that extent. So there is a targeted therapy which is there.
Okay, sir, you talked about targeted therapy, and we have a lot of progress in asthma, especially with the monoclonal antibodies coming in. Sir, at what stage do you decide that this patient is going to require more monoclonal antibodies and he will not respond to inhalers alone? Because we know that biologics are very costly. So, your comment on it?
So patients who have been thoroughly evaluated on the basis of history and examination, and once you have identified the triggers, you know that there is nothing, as I told you, the moisture in the walls and other smoke. So you have been completely satisfied that triggers have been taken care of. Comorbidities, GARD, sinusitis, other things, obesity, all these things have been taken care of. And your patient still has, for example, asthma, which is poorly controlled. You check the inhaler technique, you check the inhaler, you check the device, and you are checking the peak flow also at home. The variability ho rahi hai. Patient is not lying. At least the dosage is proper. And you have a moderate to severe asthma which is uncontrolled. Even with that, and then you do your blood test, and you find that there is evidence of inflammation in terms of eosinophilia or IgE, then is the time when you actually have to think about it. And actually we start thinking about it much earlier, but to propose that to the patient has to reach that level where you feel that yes, we are exhausted, really exhausted. Because it is a therapy which is given maybe twice monthly or on a monthly basis, and the studies have been for a year. And in some studies maybe 2 years. But to take the patient to that 2-year level, it is very difficult because cost comes. So we have to be perfectly sure. And I have used it in many patients which have shown substantial improvement. And then they are satisfied कि यार ये काम कर रही है, इसको चलो पैसे जोड़ते हैं, महीने के महीने we will keep on taking. And yes, there is a limitation of studies which don't guide about the duration. हमें नहीं मालूम 2 साल के बाद कब तक ले जाना, whether there is a side effect or not, we really don't know. But yes, there is a few studies which will come of a 10-year database which is coming up. So we will be interested in seeing those studies.
Sir, there is a question that many of my friends would like to ask here. I referred a case, 8-year-old child to Dr. P.K. Mangla sir. You would remember it, sir, the child was from Mumbai. And we were taught in Safdarjung Hospital by Dr. J.P. Puri sir that in childhood asthma, the child outlives asthma. By the time the child is 14, 15, 16 years, it is likely that he or she will outlive asthma. Sir, I want a comment from you on childhood asthma and what is the prognosis we should give to the parents when we have a child 7, 8 years coming with severe bronchial asthma. What should we tell the child, the parents, because they are really, really worried. So what is the prognosis of childhood asthma?
You have answered also, and you have asked the question also. So I also believe in the same statement as Dr. Puri sir said, because the studies have consistently shown that the children who are diagnosed with asthma, number one, they are diagnosed wrong. Because most of the children may be having a rhinitis or a sinusitis or a reflux is a very common problem. Because mothers don't know what, sometimes they will give anything to the child. And reflux is a very frequent problem which I have seen. I don't see very young kids, but I see ages 10 and above. So in those patients I have identified gastroesophageal reflux and rhinitis only, which can sometimes come up with wheezing and all, sputum secretions. And these patients improve with a lot of anti-allergics and sometimes as well as nebulizations. And I have seen patients getting cured. After 15, 16 years, they are not coming. I know some of the families which are not at all on any medicines. So the child lungs as well as the mucosa, upper or lower, they are in underdevelopment. And we know that there is a allergen desensitization which happens in our body also. So if you are exposed to allergen, then the body tries to neutralize it. And there is a capacity in the child to outlive that. So yes, I have seen patients who outlive their asthma, who are off medicines. And it's a valid point to make and counsel the patient on that.
Thank you, sir. Sir, I also want to know from you, we were told about adult asthma, once an asthmatic, always an asthmatic. Once a hypertensive, always a hypertensive. Once a diabetic, always a diabetic. Sir, for adult asthma, does that hold true? And the combination therapies which you were told, is it for life? Do we tell him that, boss, you have to be on this? Maybe the doses will become less at the times when you are feeling good, but it cannot stop ever. So you comment.
So I think again this is a matter of counseling the patient. We know it's a chronic inflammatory disease. Chronic inflammation can improve, it is not going to go. And asthma is a treatment which lasts for many years, maybe lifelong. The important thing which we want to do in asthma patients is that we want to taper the dose of asthma medicines, we want to lower the dose of steroids so that the complications are less. But yes, the treatment can be lifelong.
Sir, my last question. So you mentioned about the role of steroids, inhaled as well as oral. I was doing my MD in '86 and we were using a lot of oral steroids. Now we know that they have terrible side effects and we have seen the side effects, post-COVID. Now a lot of patients are coming with fracture neck femur because we used unconventional, very high doses of dexamethasone or other steroids, and we have one small fall in bathroom and they have fracture neck femur. Not only female patients, even male patients. Sir, your comment on the role of oral steroids versus the inhaled steroids.
This is for asthma, I believe.
Yes, sir.
So asthmatic steroids are an important part of treatment. Inhaled corticosteroids are the gold standard of treatment. These steroids are reserved for patients with very severe exacerbation presenting to the emergency. Or sometimes even at home, when you assess that yes, the exacerbation is severe enough to warrant a short course of steroids, the recommendation is 40 to 50 milligram of prednisolone for 5 days.
So it has to be a short course.
That is it. Don't taper it beyond 5 days.
And therefore, when we use a short course, we don't have to taper it. We are not obliged to taper it.
No, the recommendation is very clear. 5 days.
Right. We have Dr. G.S. Grewal sir here. He is dealing with the elderly program, and I would request Dr. Sushil Kalmas. Devin, where are you? Where are you? Sir, just now we are not asking you to ask any question. We just want to honor you. We just want to honor you. Yeah. So yes, we want to honor Dr. G.S. Grewal sir. And sir, with your blessings, we have been able to accomplish the 835th continuous CNE on behalf of Physicians Forum of India. I want you to have a cup of tea in this cup, specially designed for you. Thank you.
Well, there were two sort of attractions to come today. One was, of course, I must confess, I get a message every day, every week on Monday morning from Sushil Chauhan to come for this meeting. And I must confess that it's a very lovely feeling, Prashant, to get this message from this young man. It's a great thing, because not just because he's doing a CME, but he's a committed, passionate guy. And that's my salute to him. I salute his passion, I salute his commitment. And I also, whenever I get a message from him, invariably, I also feel pleasure and proud to remember Professor Chauhan. His wife, call it a pleasure. And my second reason today was that Prashant is also a dear friend. And asthma and COPD. Now I'm going to provoke Sushil Chauhan. And I'm going to provoke Professor JPS Tulsi. And I'm going to provoke all of you. How much of knowledge and skill that we acquire at these sessions do we translate into our daily practice? At times, Prashant, it is shameful to see prescriptions. It is shameful to see prescriptions. There was a time when I was at the Delhi Medical Council Discipline Committee and I was sitting at the stage and we asked a consultant to read his own prescription and he could not. His own prescription. So let's understand, quality of care is not only based on knowledge. Quality of care is 75% your passion and your commitment. So, this forum, with this guy's permission, I'm sharing with you today. For the last 2 months, I've started taking photographs of prescriptions, which I will share with only one person, and that his name is Sushil Chauhan. And I will leave it to his discretion what to do with those prescriptions. Yesterday I had a prescription of a distinguished Prashant, so-called respiratory specialist. Third drug was AB filing, and fifth drug was collective. I rang him up. You all know me, Pagal Admi. I rang him up. I said, what is the rationale of collective? कहता वो AB filing से palpitation होती है ना, वो collective से कम कर रहा. How many of you would justify such a prescription? No. Now the time has come where this scientific forum, we should start discussing such prescriptions. The time has come where we have to call a spade. And I know this guy can call a spade. So I'm going to give you prescriptions, you deal with the way you want, but I'm telling you, very tough times are coming forward. Very tough times are coming forward. And the most apparent tough time is going to come is in your prescription. That's all. What you have written there is going to be. आपने डॉक्टर साहब लिखा कि नहीं लिखा? नहीं लिखा तो क्यों नहीं लिखा? आपने लिखा है चेस्ट पेन. आपने लिख दिया पेंटोसिड, कोई बात नहीं. ECG भी नहीं लिखा. अगर क्वेरी एमआई लिख दिया, फिर आपने घर कैसे दिया? So let's be understand. I think one of the sessions, Sushil, you should take up on rational, safe prescription. I'm not using the word legal. Rational, safe prescription. You'll do it. Thank you so much. God bless.
Thank you. Sir, thank you for coming, Dr. Grewal, sir. I would say it has been a humongous effort to get Dr. T.S. Grewal to the forum. Every time he says, TY, thank you. We'll try. This time he has tried. Yes, I know there are many questions. I would just a minute, sir. Dr. Sharad Gopalan, who has been my student at Sadhudam Hospital, is a renowned pediatric gastroenterologist, DM Gastro. Let me tell you, his father was the director of ICMR. He, Dr. Sehgal sir has left, I think. Dr. Sehgal sir has gone to the loo, he will come. So he cannot just say a word from there. I request Dr. Sharad Gopalan to ask the question.
First, let me just thank Dr. Sushil. First time I'm coming for your meeting full time.
Welcome.
In the forum. And I'm the odd one out as a pediatric gastroenterologist.
You are welcome.
And we have an association of 37 years.
Absolutely.
Where you were a second year PG and I was an intern.
Yes.
In Satyadev Hospital. Dr. J.C. Suri.
Yes.
So those are fond memories. Thank you.
I have mentioned the master.
Thank you. My question is to Dr. Prashant. GER, GERD and bronchial asthma. In children, we are quite often frustrated because where there's an overlap, we don't have an anti-reflux agent. Whereas the ideal agent for GERD is not a proton pump inhibitor or an H2 receptor antagonist, but an anti-reflux agent. Something which prevents the stomach contents from coming to these effects. Now abroad, where I worked for 3 years, we have excellent formulations for infants. In India, whatever is available as anti-reflux agent is licensed for 12 years and above, which is ideal for your age. So my question to you is, in your own clinical practice, approximately, you may not have exact figures, what proportion of your patients do you see as being contributed by GE reflux, GERD, aggravating your bronchial asthma? The coexistence of GERD with bronchial asthma in your patients, and do anti-reflux agents rather than, or maybe a combination of anti-reflux agents and proton pump inhibitors or H2 receptor antagonists or anti-reflux agents alone, do they actually help? This is.
I think excellent point.
Basically, we are discussing pediatric bronchial asthma.
No, it's not pediatric.
No, he has understood the question.
So, valid point. And probably I would, if you want a percentage, I can give around 10 to 15%. There's a lot of GRD, APD, acid reflux disease in the Indian subcontinent because of our eating habits. And definitely, PPI alone is not the gold standard of treatment, as you rightly mentioned, but we use PPIs because that is the important component, because in future they may develop ulcers and other things. And along with that, I use anti-reflux. So my strategy has been very clear. My patient, see, the patient is coming to you in exacerbation. Obviously, he needs immediate relief. So the first prescription has to have these medicines. I don't know, I take history of reflux, but definitely yes, for the first week, we do ask them about the eating habits, about the, bread pakoras, samosas, kachoris, all these things, which is a normal routine. And around 10 to 15% of the patients are there, which must be, severe. And I always take help of my gastrointestinal colleagues, which is very important.
We are coming to the end of this wonderful CME. We still have 10 to 15 minutes. And sir, I'm sorry, your DM chest, I will start now. Simple, we will start. We will start with simple questions with Dr. S. L. Kantur, sir.
Obesity, what is the reason? Is there adipokines which are responsible as an inflammatory cause? Let me have to dilate upon this.
So obesity, obesity, one of the major reasons is the centripetal obesity, and it causes a lot of reflux, as we were discussing.
There is some inflammatory also.
Obesity is an inflammatory process, it has been proven recently, and asthma and COPD are also inflammatory diseases. So there is a link between the inflammation caused by obesity and these processes. So this is
one more term, thymus 1 and thymus 2. Thymus 2 is, eosinophilic type of the asthma. Thymus 1 is, milder, and there is what is the, is it, they are like that, sir?
no, they are not like that. Inflammation in obesity is known as specific.
I am saying asthma. Thymus 1, thymus 2.
This is the classification of asthma which was prevalent a lot of years back.
Not applicable now.
Now we don't follow this.
Okay, sir, one more question, okay? Then I will. This alpha, 1 antitrypsin, is there some, if there is deficiency of this thing, is there something more, progressive course in COPD than those who have this?
Alpha-1 antitrypsin deficiency definitely causes a progressive emphysema, and it is a very dreadful disease, and people have symptoms of COPD to present with, and then once you examine them, you find contributing factors are not there, and with a typical upper lobe distribution of emphysema, then you investigate the alpha-1 antitrypsin. Therapy is available now, but mucolytics, therapies, these are all very, very remotely used, because the availability is not there. It's very difficult to make that.
Sir, go ahead.
So, that was wonderful talk.
You have 10 minutes, sir. You can dissect out Dr. Prashant Saxena today, sir.
Nobody can dissect them, but let's proceed. So after those words of wisdom from Dr. Chauhan and most of our colleagues, let me ask you some very simple questions. So Dr. Prashant, talk us through the red flags for admission to the ICU. Confusion, lethargy, respiratory muscle fatigue, worsening hypoxemia, respiratory acidosis, pH less than 7.3, as well as impending respiratory failure. So talk us through the red flags which would probably you advise admission to the ICU in case of bronchial asthma or COPD. Talk us through the red flags, sir.
In general, these patients present to you in the emergency and very less patients come to the OPDs. And you have mentioned the red flags already. But for me, the patient, it comes with experience. You have to identify the patient who is going to develop a respiratory failure very fast. So for me, a confused, drowsy, and a weak, obtunded patient is very important, especially in a COPD or asthma. If a patient is like this, I know this patient is having a COPD asthma, immediately I should. No way I am going to look at his SpO2, no way I am going to look at his respiratory rate. I know this patient is going to die. So that is number one. Number two, very obvious accessory muscles, obvious wheezing you can hear from a distance, flaring of the LA and the accessory sternocleidomastoid, indrawing of the ribs. These kind of patients, they don't need a calculation of heart rate, respiratory rate, SpO2. Clear-cut signs, red flags. These are two rest you have mentioned, the respiratory rate, pH, ABGs.
Let's proceed further. After SABA, ICS, systemic corticosteroids, antibiotics, and NIPPV, which would be non-invasive pulse pressure ventilation with CPAP or BiPAP, which will improve alveolar ventilation and reduce the need for intubation. So talk us through these three.
So the patient of acute exacerbation of OAD in general comes to the emergency. The first lesson which we have always taught them is to support the respiration. And there is a tendency to start with nebulizations. Nebulizations are short acting. We have got new drugs, but the traditional drugs are a combination of SABA and ipratropium, which is your classical SAMA, which is your dual in.
And ICS.
Yes. And you give injectable steroids in doses which are mentioned, 40 to 50 milligram equivalent. And if there is a patient of COPD patient will present with type 2 respiratory failure, which is a alveolar hypoventilation due to exhaustion of the respiratory muscles. So you have to support the ventilation in these patients. So NIV is the first modality of choice in patients of COPD. So in the meantime, you have done the ABGs also, and you see a type 2 respiratory failure. In contrary to asthma patients, there have been multiple studies which have shown that NIV may not be very useful in asthma patients. So it is very important. Why? Because asthma is a problem of bronchospasm. Your airway is closed. Until the airway is open, there is no way you can open it with a positive pressure. So if you are using a positive pressure ventilation in an asthma patient, there is a chance you can cause barotrauma, pneumothorax, a subcutaneous emphysema.
But in COPD, probably
very careful in COPD in asthma patients. So it is not a level 1 indication. In very selected chronic asthmatics, जो कि COPD की तरह behave करता है, उनमें use कर सकते हैं. But for acute asthma, no. And yes, NIV is a great modality. I have seen many patients. I have saved many.
So to proceed further, so Prashant, talk us through the side effects of beta agonists and anticholinergics. High doses, 31% risk of ACS, which is an acute coronary syndrome, and heart failure as well. And this usually occurs within the first 2 to 3 weeks. So probably you have to be judicious in using these drugs, the short-acting beta agonists. Talk us through the side effects, the ACS with the short-acting beta agonists.
So we have been talking about ACOS, which is asthma COPD overlap syndrome. Nowadays they are talking about CCOS, which is COPD cardiac overlap syndrome. And you know, the primary pathology is inflammation. Both the disorders are inflammatory disorders. And the cardiac, if you have a COPD patient or an inflammatory problem chronic, heart will get affected. If you have a heart problem, the lung will get affected. So you have to use the drugs very wisely if you have a primary pulmonary problem to deal with. And beta-2 agonists, as I told you in my asthma slides, they have been out of the guidelines because of the same reason, because they increase mortality. They have got tachycardia, cardiovascular side effects, increased risk of ACS, MI, sudden death, and ipratropium, obviously we know there is a dry mouth, anticholinergic side effects. So we are not wanting to use these medications except for an emergency.
So, Dr. Chauhan said just 3 minutes, so 3 questions. Cardioselective beta blockers, at least one Scottish study involving more than 6,000 patients over 4.5 years said cardioselective beta blockers reduce exacerbations and reduce all-cause mortality and reduce ACS as well. Talk us through the cardioselective beta blockers and which beta blocker, cardioselective beta blockers would you like to use?
Yeah, so it used to be a conception that beta blockers are contraindicated in patients of...
As in heart failure?
Yeah. So this is not, as you mentioned, the study. Studies have shown that if you are using a cardioselective beta blocker, it actually improves the cardiac function and reduces the mortality. So if you have a patient which has got a cardiac problem and a COPD, then beta blockers, cardioselective beta blockers should be used, and nebivolol or carvedilol are the drug of choice in such patients.
My second last question, Dr. Prashant, will be our friend LFP is sitting with us regarding the diplomat. This seems to be the game changer here. You see, this was approved in 2016 for bronchial asthma, for rhinosinusitis, for chronic tachycardia, and for polyposis, nasal polyposis with great results. So the phase 3 trials, the Warriors trial, I'm referring to, this is the phase 3 trial, and they said this seems to be the game changer now, especially in COPD patients. Talk us through the diplomat.
So it is very clear, as I discussed, the use of biologicals. Once you have a patient which is uncontrolled on the present available therapies, you have taken care of the comorbidities, triggers and everything. High eosinophilic inflammation, that is very important to note in mepolizumab. And if you have got this kind of a patient, yes, mepolizumab has been used.
No sir, I'm talking about diplomat.
Diplomat I have not used because it is available. Dr. Paul. So it is a trial drug, but I have not used it.
I said this is completing phase 3 trials. I am referring to the OPRESS trial. My last question, sir, and Dr. Chauhan is pointing his watch, his smart watch to me. The Zephyr balls. See, this again has been approved by the US FDA in January 2013. Previously we used to have, see, for COPD with asthma, lung dissection and lung transplant. Zephyr balls probably is again a game changer here. Talk us through the Zephyr balls in treating COPD with emphysema.
So this is basically a sort of lung volume reduction procedure where you use these techniques, and it is a bronchoscopic technique, and the problem with the technique is that it's a very high cost. A single device costs 2 lakh rupees, and that is the problem. That's why it is not coming into India. I have been trained into this. I have got training for this, but let's see if the cost commits. I will use it. But emphysema is a wonderful therapy.
Thank you, sir.
I think, friends, Dr. Prashant Saxena deserves a big hand from all of you.